Good evening and welcome to this evening's webinar, Everything You Always Wanted to Know but Were Too Afraid to Ask. For those of you I haven't had the privilege of meeting before, my name's Annalene and I'm the Senior Dental Legal Consultant for Dental Protection, and I'm joined by my dear friend Erica Hwin, who's the voice and founder of the Graduate Dental Podcast. So good evening, Erica.
Good evening, Annalene. Thank you for having me here.
Well, thanks for coming.
Yeah.
I want to start off with just a little bit of housekeeping to begin with. So it's our intention for this webinar to run for around 60 minutes. And as those of you who have attended will know, you had the opportunity to pre-submit questions. So thank you to all of you who have pre-submitted questions. We've had some fantastic questions come through and they've given us some real food for thought. Now you can ask questions all the way through, and you do that through Facebook, and Erica's going to be monitoring that for us. I also wanted to thank Brett, our IT technical support person, who is keeping this running for us and using technology that far surpasses anything.
Yeah, it's phenomenal. It's been wonderful.
We understand. And the only other thing I wanted to tell you is there's a code for the CPD, a QR code that you can scan. Preferably at the end of the presentation. That's how you access your CPD certificate and also give us feedback. And feedback's so important because from feedback we learn and grow. So without any further ado, I think we've got so many questions. We should probably get started.
There are so many of them, Annalene, and I think these have been wonderful. We've kind of talked a little bit about them off camera, and I think particularly for our audience, just recent grads, these are the burning questions that we all inevitably all think, but we're too scared to ask them. So I hope today we're able to just, break down those barriers and just openly discuss, and who better to talk to than yourself, hey, Annalene.
Thanks, lovely.
So let's jump into it. The very first question, I think, is a scenario that we have all been in. And the question is, if an endodontic retreatment, so redoing a root canal, is indicated for a tooth, but I was the one that carried out the initial root canal treatment, other than full disclosure of the circumstance to the patient, what else should I be telling them? How do I guide my patient? What do I do about the scenario?
That's a great question, and I think I'm going to be saying that a lot this evening. That is a great question.
There are a lot of great questions, eh? Yeah.
But also, it's a really, really common one. So just to be clear, your root treatment's failed, and that patient now needs to see a specialist.
That's right,
The colleague who sent that in is absolutely right. There does need to be open disclosure to the patient that the treatment hasn't been successful. Now, I would just say, stepping to the side, don't beat yourself up about that too much, because everyone's treatments fail sometimes. Endo's really tricky. And particularly for recent graduates, it would be the procedure that we see go wrong the most for recent graduates.
The one that we're most scared about as well, right? Like, can I do this? Will it work?
And that's okay. And we talk about this all the time, Erica. Dentistry is a really steep learning curve. But absolutely right, this colleague's identified that it hasn't worked and they need to do something about it. So we need to tell the patient it is appropriate to apologise. Now, we're not saying, so I'm sorry, what I did was rubbish. We're just saying, I'm sorry that this has happened, because it doesn't mean that there's anything wrong with what you've done. Sometimes treatments fail. I do want to be clear for anyone who's listening outside Australia that in Australia, an apology is not an admission of liability. So if I apologise to you in the dental surgery because something's gone wrong with my treatment, that can't be used against me.
You're not assuming fault for it.
That's right. So I think people worry because they think it's like the old car insurance stuff where if somebody hit your car and you said sorry, that you were accepting blame. That's not the position of the law, and Australia is quite unique. I think Ireland now have that legislation as well, where an apology is protected, but it's something quite unique to us. So apologise to your heart's content.
And I think that goes a long way as well, just saying to your patient, I'm sorry this has happened to you. Right?
It's good for both of you, because it's good for the patient to hear the apology and to know that you care. But actually there's a lot of evidence that apologising for someone, it kind of puts you at peace as well, because you feel like you're being honest, and it just enables you to get that I'm really sorry off your chest. So we've apologised and we've told the patient the truth. Now we need to get them fixed. So a referral is appropriate. And oftentimes that referral is to a specialist endodontist, because endodontic retreatments are tricky. That said, there may be circumstances where there is a more experienced clinician in your practice who's able to take over that treatment. So we need to apologise, be honest, and put that patient on a journey to get them fixed.
Sure.
Those are the steps you need to take.
Who pays for that?
It depends.
Yeah.
So I would say that if your treatment's failed, it may not be appropriate to take the fee for that. And it depends why it's failed. But if a patient's already paid a couple of $1,000s for a root canal treatment, it would be understandable that they don't want to pay for it twice.
Yeah.
And the specialist fee will be more expensive. So it may be appropriate to consider transferring your fee that you paid to the endodontist to put towards the patient's treatment. The other thing I would say here is when you start talking about money and refunds, it's a really good time to ring your indemnifier.
Okay, sure.
Because there is money there to help with things like failed treatments, and it might be that your indemnifier can help financially. We try and make it so that the patient doesn't have to pay twice, but also we don't necessarily want you to be suffering financially and paying out for all this treatment that when you only earn this much for it.
Yeah.
So that's where your indemnity comes in, just to help be fair to everyone, but it's assessed on a case-by-case basis. So ring your indemnifier.
So if we ring our indemnifier, how do we do we have to talk them through that whole process? Does it become this claim, or how does that work?
It's called a claim, but you don't tell the patient.
Okay.
So I don't mean you don't tell the patient in a negative way, but if you're saying to the patient, this has gone wrong, I'm really sorry, I'm going to send you to the specialist, and and the patient says, look, am I going to have to pay twice?
Yeah.
And it's okay to say, I need to seek some advice. I'm not sure, I've never been in this situation before. If you say to the patient, I'm going to ring my insurer, what the patient hears is, I will be getting a Ferrari and a unicorn.
Sure.
And also, it takes all the goodwill out of a goodwill gesture.
That's fair.
And that's what it is. It's a gesture of goodwill. You're saying, I want to help.
Yeah.
But someone else is going to bankroll it, so I'm not really helping.
Yes.
So you don't say to the patient
directly, explicitly to the patient.
Yeah. And it's not about being tricky or deceptive. It's just about, it's between you and the patient, and your relationship with the insurer is separate. The patient is not making a claim on your insurance. The only person who can claim on your insurance is you.
That makes a lot of sense, and I think, as you say, the most important thing to preserve is that relationship and that rapport with the patient, and knowing that you are doing it as a gesture of goodwill. You don't want it to seem icky and to seem sneaky by mentioning those things. Yeah.
Some might ask, and if they ask, then it's okay to have that conversation with them. But what you don't want to say is, I'm sorry, I'm terrible, everything I've done's wrong, I need to ring my insurer. It doesn't instill confidence.
Okay, fair enough. Building on that question of when to contact an indemnity, I really love this next question that we have here. And this obviously happens to all of us, but if a patient has a treatment complication, and let's take like the classic example here, they've said the root in the sinus, which I think we say at some point in all of our dental careers is bound to happen. This happens, but we haven't warned the patient that this could happen. What do I do, Annalene?
First thing, don't panic. It's a root in the sinus. If you haven't done it, you just haven't done it yet. And it is a horrible feeling. So you're pushing and the tooth's not budging, and then there's this like moment and time kind of slows. So don't panic is the first thing that I would say. Okay. Now, ideally, we would have a conversation with a patient about all the risks and warnings before the treatment. And I know that that's really difficult, particularly as a recent graduate, because there's always that concern that if I start saying, oh, then this can happen. Oh, and then this can go wrong. Oh, and then this can go wrong. That we're talking patients out of treatment, or that they'll lose trust in us. But it's an important part of the consent process that patients know what can go wrong during their treatment and what's going to happen if something does go wrong, and any additional costs associated with that. So if you've skipped that step and pushed a root in the sinus, look at you, oh, stressful. Then you are liable to liable for the remediation costs. What does that mean? It means that the patient shouldn't have to pay to get fixed, because technically
you didn't warn them.
You didn't have consent. If you didn't warn them, then you don't actually have valid consent in place. So you're liable for those costs. So what we do in the short term is we don't say to the patient, hang on, I need to ring my insurer. We sit the patient up. We tell them what's happened. We say sorry. We say, I'm going to refer you to the specialist, because we need to do that. We need to refer the patient to the specialist for an assessment to see about getting that root out of the sinus.
Would you be covering their costs to see the specialist?
I would say I would offer to pay the cost of the consultation. Because the reality of it is that one of the clauses of an insurance policy is technically you can't spend their money without talking to them about it. But they're highly unlikely to snake you. We certainly wouldn't. But you don't actually know what's going to happen yet. And so you have to be really careful saying, I'm going to cover the costs of this. So what you would say is, I'm going to refer you to see a specialist colleague, and I'm going to cover the cost of that consultation, because I think it's important that we both know what needs to happen next. Then, when the patient leaves, a small cry, cup of chamomile tea, ring the specialist rooms and say, hello, this has happened, I've sent them to you. If you can speak to the specialist, brilliant. You can't always with max faxes because they're often in theatres. I would identify yourself as a recent grad so they know, and then you need to ring your indemnifier. And they're going to need a complete copy of the records and to see what's happened. When the report comes from the specialist then, it will tell you what the patient needs and any associated costs. And what will often happen then is we will help you write a letter to the patient explaining what's going to happen next and setting out what costs you're going to cover. Root in the sinuses are tricky because there's the private costs with the max fax. The patient may have private health insurance which will contribute. You've also got the anaesthetist costs. And then that's bulk billed through Medicare, but then there's a gap. Sometimes the anaesthetist wants paying in advance. Sometimes the max fax will bulk bill you. And this is where I'd say one of the best things to do as a recent graduate is to meet your local specialists. Because if you've met them and maybe gone to observe them, if you ring them up and say something's gone wrong, you just feel like more comfortable doing it. They will always be lovely to you, particularly the max faxes. I know they seem really scary, but you wouldn't be the first recent grad who's rung up and say that you pushed a root in the sinus. But having an established relationship makes it a bit less scary. So again, apologise, explain, solution for the patient, small cry, cup of caramel tea, ring your insurer, offer to pay for the consultation. And then once you get the report, then we can assist you.
And almost guide us through.
Almost definitely the insurer is going to not make you pay for the consultation, just to be clear. But you have to go through a claim process.
And so then that's what you were saying in terms of like the treatment to retrieve the root, whatever that may be. Will that then depend on the case? Will your insurer cover all of that, or is it all that it depends?
Commonly, but it's got to be done on a case-by-case basis. Like they have to do an assessment and they have to accept the claim. But generally, if that's the situation, the indemnifiers in Australia aren't going to leave you high and dry. Like it's not. The purpose of indemnity is to access money to fix patients when things go wrong. So if something's gone wrong, they don't push you out.
I love this because I feel like for everyone that's listening, this is really great because now we know, okay, when I inevitably push a root into a sinus, I'm going to accept it. At some point, something's going to go wrong. At least I now know that I have a game plan, okay? I'll have Annalene in the back of my head saying, this is what I'm going to do, this is what I'm going to do. But I think for a lot of people, and maybe people have had this happen in the past, is I think maybe particularly as young grads, we're scared. And we're scared to tell people what have happened. And we kind of act like, is it ostriches or emus that stick their head in the sand?
I think it's ostriches. But
You know what I mean? It's just like, if I can't see it, then it doesn't exist. And I think that often happens, like whether it be like a perforation or something that we kind of just want to sweep under the carpet, refer it off to a specialist, and we might not tell our boss, we might not contact our indemnity. Yeah, I guess, do you have any thoughts and advice? And what's the risk of doing that? Because if we kind of just push it and pretend it doesn't, nothing happened, and then later, someone discovers it, and then you find out through a complaint, like, is that now a different scenario, a different pathway?
Absolutely.
Yeah.
So I think, first of all, it is perfectly normal when something goes wrong in your practice to feel a bit panicky and to have a moment where you almost can't see it. And that's a normal stress response. And you'll have that really icky sensation in your stomach, like you say, a perforation. Is it perforated? Is it not? And it's a yucky feeling, but you do need to see what's really there, and you need to step up and be a professional and act appropriately. If you don't, someone is going to find it. The chances of you being able to leave a root in the sinus or a perforation and that patient not have symptoms in the future are really, really slim. Now, if you're lucky, they will come back to you and you can discover it then and apologize. But it is as likely as not, particularly because a number of recent graduates move jobs reasonably quickly. You have a number of jobs early on, commonly. They'll go and see someone else. That person will tell them, and then the patient will go, well, Erica didn't tell me, and now you've got someone that's grumpy. Because if you tell them there and then, you control the narrative. If they find out after chronic pain or chronic sinusitis that you've done something and not told them, and someone else is now controlling the narrative, you've got no control over how that colleague tells the patient. They could say, what? She didn't tell you? What an idiot. And they can discredit, not intentionally, hopefully, but you've lost control now, and now that patient's grumpy and they're in pain and often need something more to fix them. It's not a simple fix now. And they will often make a complaint to ARPRA, write a nasty Google review, and you're still going to be liable for all those costs anyway, and you have all that additional stress. So if you can control the narrative early, you will get the patient fixed quickly, but also it's not out there in the universe waiting to just hijack you at any time.
It's that, and it seems to be that, I guess, management-wise, it's the same in terms of what patient needs. The patient will need treatment, and if you tell your insurer, likely they'll help you cover it. But it's all about the stress, the additional stress and unpredictability of it that you are no longer controlling by not addressing it.
No, absolutely right. And it's scary to have conversations like that. It's difficult conversations, are aptly named. And particularly when you have done something wrong and you didn't warn the patient, and you'll fall into that, I'm such a fool, I should have told them, I should have this, I should have that. It helps no one. Just get the patient fixed, and then we'll deal. You mentioned the boss as well. I think it's really helpful to tell your boss when you've had things go wrong in your practice. I think that I would hope that most principal dentists would be appropriately nurturing and provide you with meaningful advice. If your boss is using that as a stick to beat you with, I'm going to suggest that you're possibly not in a particularly healthy workplace, and you may consider leaving because you're not going to thrive. I'm thinking, what words can I use? Just leave, mate. Because you're not going to thrive.
Yes, that's fair. Who's going to back you? Like, your boss doesn't have your back.
We've talked about this before. But one of the most powerful things that you can do as a dentist to really freak yourself out is to look in the mirror and say, I will make mistakes, and some will be serious. Say it now.
I will make mistakes, and some will be serious.
How does that feel?
It feels reassuring to know that, like, I've taken ownership of it. I've accepted that.
That's
it's an
really
innovative.
good.
Like what I said, I will when I push a root in the sinus.
Most people say terrifying.
That
too. But you will. And, things are going wrong in your practice of dentistry all the time. We don't like to think they are, but they are. And if your boss hasn't got your back, then what's going to happen? You need to be in an environment where you feel safe.
I think that's true. We've got a follow-up question about what we were talking about before when you mentioned, like, risks and informed consent, right? How detailed do we need to go into discussing all the risks involved in, like, simple procedures?
The answer is always, it depends.
Yes.
So that's my answer to every question. So there's actually 3 legal levels of information. So this actually has a legal answer.
Okay.
So there's something called the professional standard. So that's what we as clinicians believe are appropriate risks and warnings to give a patient. So the example of extracting an upper 6 or 7, we would all agree it would be prudent practice or aid to advise of a root in the sinus. Okay, we would all agree that's prudent practice. Then you have something called the this reasonableness test, so the reasonable patient test. What would a reasonable person want to be told? A reasonable person would want to be told that a root can go in the sinus, but would they want to know some of the, or an OAC being created because it's so common? But you take jumping around, but take local anaesthetic. Some people die from local anaesthetic. There are a couple of documented cases of people who've died. Would your reasonable person want to know that in all the people in the world, there are some really rare incidences of that happening? Probably not. It's probably not they probably wouldn't want to know that. But then you have something called your specific patient test. And that's what this unique person needs to be told about the risks and warnings because of something with them. And so a case example would be if you're giving an ID block, some patients have a prolonged paresthesia, right? And it's almost always from the trauma of the needle. Most people don't need to know that. But if you have someone who's a chef, that can cause loss of taste. So that might be something that they need to know, which you wouldn't necessarily have to tell me, for example. So how detailed you need to go depends on that patient. So what do we as a profession think is reasonable? What would your average person want to know? And is there anything unique to that patient so they might need to know a little bit more? Personally, I warn all my patients I do fillings on that the tooth could die and need a root canal treatment, just as routine. I warn all my patients I do some pretty heavy duty scaling and cleaning on that they are probably going to have sensitivity. I find if I do that, they are less likely to come back with concerns. And if they don't have problems, it improves our relationship because that warning didn't eventuate.
I love it because I think it's something I talk about on the podcast all the time. And it's the golden piece of advice that every senior dentist ever gave me with communication, which is the classic, if you told them beforehand, it's an expectation, whereas if you tell them afterwards, it's an excuse. And if it doesn't happen, then you're a superhero.
Absolutely, then you're a legend because they were expecting the worst. So expectation setting, as you've said, Erica, is incredibly important. I hope I've covered that question up properly. So if I haven't, if our colleague just wants to get back to me if they want to know a little bit more.
I'll be monitoring the chat. If people have any follow-up questions, please pop them in for us to follow up on. I wanted to continue on that train of thought, Annalene, with this next question that we have, which is, I think when we talk about consent and risks and complications, there are so many things. I think it just, as a dentist, there are so many things that we need to remember and so many things that we're responsible for. And this scenario is sometimes, well, I guess, what happens if we forgot to mention a particular post-op instruction? When you think about extractions, right? Like I have in my head a list of 6 of them, and then I do have to stop for a moment to think, like, did I cover all of them? But like, what happens if, in a scenario you forgot to mention a particular post-op instruction, and then you realize the patient has left the practice? How do you then go about informing them without looking silly and unprofessional?
I wouldn't worry about how I look. I just pick up the phone and give them a ring. And so winding right back, the way to avoid being in that situation is to have a scaffold, a structure. So your written post-operative instructions that you give a patient, for example, post-extraction, using your example, if you sit with the patient, you go through that scaffold with them, you're almost always going to remember to give them every relevant post-operative instruction they need. If, however, when someone's left and you think, oh goodness, I didn't tell them not to such and such, not to smoke. Then it's okay, I think. I would just ring the patient up and just say, Steve, I'm really sorry. Sorry to trouble you. It just occurred to me, I'm not sure I emphasized or I'm not sure I told you that one thing with this tooth coming out is you're not going to be able to smoke for this period of time. Really sorry I didn't mention it before. This is why it's important, and I just don't want that to happen to you.
And I think patients really appreciate that you've gone that extra mile to remember and to contact them and go out of your way to make sure that you want them to be okay. You don't want anything nasty or any nasty surprises to catch up on them.
I think so too. And I think two things from that. One is, again, it's that controlling the narrative.
Yes. Yeah.
And that's why I wouldn't get a staff member to ring them, because
Chinese whispers as well, hey?
With the best will in the world, you don't know how they're going to present that information. And the other thing is, when you're a reasonably recent graduate, you can often feel uncomfortable if you make mistakes or if you forget things, because you're worried that people will see that you're incompetent.
Yes. Yeah.
If that's what that person thinks, then that really is a matter for them. More likely than not, you've already impressed them with your competency in the surgery, and then just ringing up and going that extra mile, it's only going to embed your relationship. And if it doesn't, then so be it, then they're not the right patient for you. But you can be at peace in your heart knowing that you've given them all appropriate risks and warnings.
And I think patients always appreciate that phone call. I remember in dental school, one of my instructors always told us that, like, if the dentist gives the patient a call, she would always say this one phrase. She's like, oh, the patients will feel like it's Christmas. And that just always stuck with me. But this morning, on my way from the, before I went to the airport, I had reception tell me about a patient that, was having pain with the tooth that we'd done a crown on, and she was seeing another dentist. I was like, can I have a phone number? I just want to give her a call. And when I called her and spoke to her, she was just like, thank you so much for calling me. She's like, I really appreciate it. No, like, it's all good. I'll see you when you're back. So I think we get in our heads about being scared to call the patient and talk to them, because they'll then think that we're less competent or think that we're, not good enough. But I think they really appreciate just that personal touch of you caring.
I think so too. And I think that you just have to be brave, because otherwise it's just out there like the monster under the bed waiting to jump on you.
As soon as I called her, I was like, oh my goodness, all that stress has gone away. I'm so glad I spoke to her.
Were you scared before you called her? Did you?
Oh, absolutely.
What were you scared of?
Because I didn't, again, this was the whole, I'll dive into this, but it was because how the story came about was that my practice manager called me as I'm getting ready to go to the airport, and she says that the patient that you did a crown on has come in for a toothache 8 a.m. to see one of the other dentists, and the other dentist says she needs a root canal, but then apparently there was infection, but she didn't know that she had it, or that I didn't tell her, blah, blah, blah. And the story just felt very muddled.
It felt very big.
Yeah, and I was like, I was just at a loss, because I'm like, oh, and then I felt bad that I'd missed something, or that I had done something wrong, and then I was worried about what the other dentist has said to the patient, and what essentially it was losing control of the narrative, because I didn't know who was on my side and what the patient now thought. And so then all I did was I just found out what the story was, what had happened, and I called the patient, and she said this one thing to me. She's like, oh, it's all good. She's like, I saw Dr. So-and-so, and she's like, I know it's always been a problem tooth. I know we need to get the root canal done. I just couldn't come in to see you earlier. It's just giving me too much pain. I'm coming back this afternoon to get it extirpated. Oh, I know finance is a bit tight, but I'll talk to you about it when you're back. She's like, I know it's not your fault. It's just a problem too. And just that one line, I was like, I'm so glad I called her, because now I can go to Sydney just with peace of mind. But it's taking control of that narrative again.
Absolutely. I think sometimes people are scared that patients are going to shout at them. I think. And I think I can understand that. But you still have to ring. And as has happened with you, more likely than not, you're going to feel so much better when you do. So much better,
because now you know. It's no longer that scary unknown. I've got one more question, and I think we'll take a little break, Annalene. But I think it's a good follow-up on that one. And this one, it just reminds me of one of my new grads that I work with. And we were saying, what happens if you miss like a post-op instruction? Let's talk about x-rays. Because sometimes you'll see a patient for a 6-month checkup, and you'll take x-rays and you're like, looks good, all good. And then you let them leave, and then later you look at it again, you're like, oh, is that decay? Or is that an infection? Is that periapical radiolucency? What do you do about that, again, without looking silly and stupid in front of your patient?
Great question.
Yeah.
So again, there's something that you can do before to stop that from happening. So the thing that you do before is what I do in my practice, for example, is I say to all patients I take x-rays from, looks good. However, I check all my x-rays at the end of the day, which I do in a dark, quiet room, away from the distractions of the rattling and the suction and the child swinging off your tray. And I go through all my x-rays again and I say to the patient, there is a possibility when I look at your x-ray the second time, I might find something. And if I do, I will give you a call. So if you don't hear from me in the next couple of days, don't worry about it. If you do hear from me, I'm sorry, but I will double check. So that means that when I check my x-rays, if I find something else, the patient's not surprised because that expectation has set. If you haven't set that patient's expectation, then I would ring them and I would say, John, I, as a matter of principle, always double check my x-rays. And when I double checked it, I picked something up. I'm really sorry. I know you weren't expecting to need this filling, but I picked it up and this is why I double check the x-rays to make sure nothing slips through the cracks. So flipping it and making it a positive thing. I do this because I'm a responsible clinician.
I love that. It's the same scenario, and it can be just framed in a positive light of you doing your due diligence, because you could very easily not have said anything.
Absolutely.
But you've decided to take ownership of it, and it's that positive spin. Whereas it could be very much like, it's how you present it, whether or not you look silly and are incompetent is your own narrative, hey?
Yeah, for sure. And I wouldn't leave it 6 months for them to come in again, because a lot can happen in 6 months.
Yeah, wonderful. Let's have a little 30-second break, and then let's get back, and people can send more questions in.
Back again.
There we go. Annalene, I know this question is one that you absolutely love talking about. And so it says, hi Annalene. Hi Annalene. I heard you say in the past that burnout didn't affect recent graduates as much as it affects us now. Why do you think that is? What is contributing to the burnout of younger dentists, and how can we avoid it?
Okay, great question. So yes, I have said in the past that burnout didn't used to affect recent graduates as much as it does now. So burnout has always in dentistry predominantly affected people between the ages of 35 and 55, which is really specific, I know. It's a 20-year period. But it's because it often related to everything happening at once. So at that time in life, that's often when people are buying practices or multiple practice owners, doing additional CPD, mortgages, increased debt, family obligations, and just so much loading, so much going on that it would just cause them to just burn out because everything was happening at once. So that's historically how burnout has manifested in dental practitioners. Now, historically, we graduated into a very, very different world. So you and I were talking about this. Even our training was different.
Very different,
and so you were telling me that you graduated in 2022. So you graduated into still a COVID landscape. Now we are seeing in a post-COVID landscape, we're calling it amongst ourselves in my team a COVID hangover. So we're finding
professional.
that patients were really angry during COVID, and we're finding that a number of people are still just feeling really unhappy with life. There's a lot going on in the world at the moment. There's wars, uncertainty. We have a cost of living crisis in Australia currently. So you graduated into a world where patients are uncomfortable in their lives, okay? And so we all have this tolerance to uncertainty point, and it's different for different people. Many, many patients have reached that tolerance for uncertainty just because what's going on in their lives. You and I both are from Brisbane. There are people in Brisbane who are not sure how they are going to feed their children next week. And that breaks my heart. And 5 years ago, 10 years ago, we wouldn't have had that statement. Not really, but it's becoming people's reality. And so you've graduated into a world where people have got a low tolerance to uncertainty. They are incredibly financially sensitive. There are more complaints against recent graduates than there used to be. And again, recent graduates rarely received complaints in the past because people were protective of you and quite pastoral and understood that you were young and you were learning. But now, because of everything that's going on in their lives, they don't have that tolerance anymore. Okay? Then everything's got more expensive. I'm sure you saw the post on DPR about hourly rates and percentages. And so I'm from the UK. In the UK, when I graduated, we were all on 50%. Can you imagine? The what? When I came here and I was offered 40%, I was like, the what now?
The what?
Like, because it was so alien to me. But then when you speak to the practice owners and you see how their expenses, which makes sense, because look at the price of coffee, look at the price of carrots, right? So it's inevitable that the price of dental materials is going to have gone through the roof too. So you're getting squeezed by the patients are grumpier, they're angrier, the principals are under financial pressure themselves. I see recent graduates going on salaries, really low hourly rates, to be honest with you. So you're graduating with huge debt. When I went through dental school last century, I didn't. I only had my student debts for my cost of living. My course was free.
Wow. What?
In the UK,
you got paid 50% and you didn't have to pay student fees.
So can you see how different that was? And so you think about the world that you're graduating into. And so I think as well, particularly around about the time your cohort graduated, how did you all find finding a job? Did you all find jobs easily or not?
I think so. I feel like if anything during my cohort, there was I think practice owners were desperate. And so everyone said to us that it was a new grads world. Yeah, because everyone wanted to hire. I think particularly there was that lull during COVID, but then there was that build up again. But then it was almost like, which practice do you go to? Because it was too much to choose.
Wow. Okay, that's interesting. I wasn't aware of that. Because I know that the cohorts before you, there were not enough jobs.
That was that's what I remember the story being. It was like before us, it was very much like people couldn't find jobs and they'd apply to 100 different clinics and get rejected by all of them. But I think with Alco, at least my year specifically, I think people were almost like, where do I go?
And and how do you choose, right? So everyone says they're going to mentor you.
Yes, exactly. Yeah.
But do they? And so, and I think that back in my day, when I used to walk to school in the snow, I had something called vocational training. So we were placed in practices with vetted ethical practitioners, and we used to do we were salaried. And we were well salaried. So it's even worse, isn't it? Like we weren't on 50% at that stage. Our first year we were salaried. So we didn't have that build up initially where you make no money whatsoever. So we all knew we were getting paid. We could all pay our rent. And we used to do 4 days in practice and 1 day of CPD. So it's in cohorts, in groups, secure groups. So that's very different to how you graduated too. So that mentorship was there. We were, like I say, we were in groups. We were very protected in that regard. And I just don't think that you have that. So difficult patients, difficult environment. Everyone's getting squeezed financially, including the principals. It's going to flow onto you. You're graduating with a lot of debt. I also think social media.
It was the big one I was going to come to.
Darling. The stuff that I see, there's nothing that's going to make you feel bad about yourself more than seeing someone else's perfectly curated.
Because you made a potato, and then you see perfection.
Don't be looking at my work.
Another potato.
Another potato. But it's true. And you've got to bear in mind that a lot of the stuff that people are showing, it is their curated perfection shots.
Highlight reel.
They're not showing their failures. I love a failure. We've talked about this. I love a failure on social media.
The graduate dentist. I post them all the time.
So I think that you're under so much pressure, and I think that there's this perpetual echo chamber around you all where I don't think, like you say, it's all about highlight reels and moments, and no one's talking about how hard it is, perhaps.
I think so.
And so you feel quite isolated and quite alone. I think so. I think it's all those things.
I think social media in particular is everyone says it's such a double-edged sword, and I feel very passionate about our generation because I think on one side of it, I have full faith that I think our generation has so much potential to be just phenomenal clinicians because we're exposed to so much and so much educational content, and there's that drive and ambition that I would argue is more in our generation than our previous generations.
I would agree. I think we're all very driven.
Yeah, and I think because of that, we'll upskill very rapidly and quickly. I mean, we see recent grads now that are doing work that's like phenomenal and it's incredible.
We do.
But then there's the flip side of it is that there's that constant comparison and that constant, I'm not good enough, I'm not doing what other people are doing. And so, as you said, you've got all the other external things that are making dentistry difficult, and then also you're battling your own challenges of not feeling like you're good enough and not living up to these expectations.
Absolutely.
Yeah.
And I think I do think that's a really, really good point. I do think as well, Erica, it's important that people remember that they're on their own journey.
Yeah.
And I always say, Class 2 composites are among the hardest things that we do. They're so hard, man.
I hate them. I thought I'd be good at them by now.
Have I not arrived yet? So someone else is like, oh, I'm doing all on X. And you're like, I'm struggling to...
Still shredding my floss.
But that's normal.
Yeah.
That's normal.
That's
and
what
I think
we're not normalising.
Yeah, and we do need to normalise how hard it is. It is a steep learning curve. It really, really is. And just because that kind of just because someone else is doing implants or someone else is doing ortho, that's got nothing to do with your journey. And I don't think you should feel pressured. That comparison is so strong.
Yeah.
I just don't think you should feel pressured. Just you know, just do you.
Focus on you. Speaking of social media, this is something that both of us were very excited to, I guess, dive into in today's conversation. Is there's no denying it that social media has such a big impact on us, on all of us, and in our dental industry, more so than it ever has before. And so we have, I guess, some questions related to, I guess, perhaps the legality nowadays of dentists having social media accounts, and specifically dental Instagram accounts where they're showcasing their cases, whether it is for educational purposes or whether it's to attract new patients. I feel like it's a little bit of a grey area. We don't know what we can do, what we can't do. Do you have any comments on that, Annalene?
Oh, do I have comments on that, Erica?
But tell me, yeah.
It's really interesting because there are many mature age practitioners who really dislike the social media aspect of advertising, and they think it's unprofessional and they don't like it, okay? Now that's their point of view and they're entitled to that. But I think that social media is a good thing for all the reasons that you've said. People are very interested. I find your generation are very interested in building your brand. I love that for you. This my brand. It's fantastic. Fantastic. I only found out 2 weeks ago what a fit check was.
Oh,
incidentally.
we'll do one later.
I thought a fit check was when you tried on your veneers. I didn't realise that there's actually... Anyway, love that for us.
Yeah.
So, there are rules around what you can and can't do on social media, and you will find those rules on the Dental Board webpage. If you go to policies, codes and guidelines, you click on that, there is an advertising hub and there is a social media hub. Now the guidance at the moment is, I wouldn't say it's grey, but if you were to read the guidance and you were to watch what some people were doing on social media, the two wouldn't appear to have much in common with each other. It may interest you to know that 50% of the advertising complaints to ARPRA annually are dental practitioners. So we're copying a lot of the complaints because of the stuff that people are doing on social media.
Okay.
So a number of people are breaching the guidance and not realizing until they're reported. And then they're having to go back and tidy their social media up. So that's the current state of play now. Of more interest to me at the moment is the Dental Board have put out some advanced guidance, and Brett's going to share that for us now. So this guidance can be found on the Dental Board webpage, and it's going to be the rules from the 2nd of December, and it relates to the advertising of non-surgical cosmetic procedures. Now, this is confusing to a lot of dentists because they think, what has this got to do with me?
You did a law degree, we didn't. We're getting the TLDR right now, right?
But also, we don't do non-surgical procedures because we cut teeth.
Yes.
Okay. But the dental board have the definition of what a non-surgical cosmetic procedure is nearly half a side of A4. But the dental board have been very, very clear about what it involves. Now, I just want to talk through a bit of this because I want you to share with me or to go through to understand why the regulator is worried about advertising.
Okay.
Okay. Non-surgical procedures, this is the definition, undertaken to revise or change the appearance, colour, texture, structure or position of bodily features with a dominant purpose of achieving what the patient perceives to be a more desirable appearance. Now, there's your first problem, because how many times have you done work for someone or you've seen work done for someone and you think it's beautiful and the patient doesn't like it? It happens.
It does happen.
It happens. Body dysmorphia is a thing, and body dysmorphic patients are attracted to getting their teeth fixed.
Yeah.
Okay. Now, the practice of non-surgical cosmetic procedures can be lucrative, and financial gain can compete with and sometimes outweigh patient well-being and safety considerations. Now, this is the dental board's position. It's quite frightening, isn't it? That's what they believe to be true.
Yes.
Why do they believe this to be true? From the complaints that are coming in.
Okay.
They haven't just like imagined this.
This is what's guiding them.
Correct.
Yeah.
That's what's informing their position.
Sure. Yeah.
Like all cosmetic procedures, higher risk cosmetic procedures are often sought by particularly vulnerable people. So they're talking about body dysmorphia, they're talking about people with mental and emotional anguish who genuinely believe that if they get some veneers, that everything in their life's going to be good, and unfortunately it isn't. You know, their life's still going to be their life. Okay. We know this relates to us because it then says examples of higher risk cosmetic procedures include but are not limited to dental veneers and the administration of cosmetic injectables. So this relates to us now. There's two documents, as I showed, that sit side by side.
Yes.
There's the guidelines for people who perform, and this is all about how you do it, how you prescribe fillers. The bigger document is how you advertise them. And there is a whole section in there even about the type of music that you have on your social media. And I think that I would encourage anyone who is looking at, I'm a recent graduate, I want to start putting some of my work on social media, I want to build my brand, I want to attract patients. Don't just look at what other people are doing. And in fact, maybe don't look at what other people are doing at all, because a lot of what other people are doing is in breach, bearing in mind 50% of the advertising complaints are about dental practitioners. Okay, so a lot of us are in breach. Have a look at the guidance, which is the now, but definitely be having a look at this, because some of the stuff that you may wish to do from the 2nd of September, it's not going to fly. So
because this isn't enforced right now. This is
2nd of September it comes in. Okay. So it's really important that anything that you do complies with the ARPRA guidance. All ARPRA guidance, when you sign your registration every year, you sign to say that you will comply with all rules, regulations, policies and guidelines. So when you renew on 30th November and you sign that declaration, you are saying that you are going to comply with this.
So what happens from, is it the 2nd of September? What happens? It's so sinister, Annalene, but I guess all these people that you say that currently have social media posts with scandalous music, right?
I know, right?
And all these things that, I mean, there's the whole document's got so many really specific things that aren't allowed.
Doll
aren't
maker.
going for. I know, right? You showed me before and I was like, jaw dropped reading these. But what happens? What is the consequence? Like, am I getting arrested?
Well, they're not going to take you out the back and shoot you.
Okay, sure.
What normally happens is you get a shot across the bow at first.
Okay.
So if there's an advertising breach at the moment, and we have no reason to believe that they won't behave the same way from 2nd of September, you get a shot across the bow from the dental board. So you get a letter saying your advertising's in breach, and it has like 3 words. It's like review, fix, don't do it again, but they're slightly different words. And they'll give you specific examples of posts that are in breach. And they will often tell you why. So at the moment, the social media guidance has got like a whole section on testimonials and creating unrealistic expectations in patients. That will still stand. But it's just got so much more colour to it now. So they'll give you an idea which posts are the problem, and they'll give you an idea why. And then essentially you're supposed to correct that. And by correct that, they mean take it down. We then help you write a letter back to them saying, really sorry, I didn't realise, because you didn't. I've taken the post down. They will then re-audit you. And if you haven't taken the post down, or you continue to post stuff that's in breach, they will often give you a second shot across the bow and say, hey, stop it. If you continue to be, and they'll audit you again 3 or 6 months later. And again, if you've done something wrong, then they start to get cranky, and then they start to take actions against your registration. So commonly you'll get a caution. You can also get a fine for inappropriate advertising.
What's a caution? What does that mean?
So when you have an investigation with the dental board, with ARPRA, there's a couple of options available. So the majority of complaints are dismissed, no further action, Then the worst is obviously to be suspended or to have your registration erased. That happens to very few practitioners across Australia, you'll be pleased to know. Most people it's somewhere in the middle. So the lowest level is something called a caution. That's like getting points on your driver's license. No one can see them, but you wouldn't want too many. But if the police look at your license, they know it's there. So ARPRA know the caution's there. Cautions are not visible on your registration. The next one up is something called a reprimand, and that is visible in your registration. So when you look, it would say Erica Hwin reprimanded, yes. And it sits there for 12 months. And then we can apply to have it removed. And then you can get something called conditions or undertakings, and they tend to go hand in hand. So it will be, the condition is that Annalene can't do any molar endo, breaking her heart about that. Sorry.
Tragedy.
Until she undertakes this much CPD, or she's supervised or whatever. So there's like conditions that have to be met, and once those conditions are met, then that undertaking is removed from your registration and you go back to an open registration. So commonly for this you will get a caution. And possibly a fine.
But they're giving you some warning beforehand. You're giving a few chances before.
They have in the past. We don't know what's going to happen. This document doesn't actually make reference to what they're going to do, but I've got no reason to believe that they're going to be more militant. I think the important thing is, first of all, let's not get ourselves in this situation. And if we do get ourselves in this situation and the dental board tell us, then let's get that fixed. Hey, let's not be belligerent about that. It's important that you know, is regardless of who does your advertising, so you could have an independent person who does your advertising, you could be part of a practice and someone within the practice does that advertising. You as the registrant are responsible. So that's important to know too. So just because someone else tells you it's okay, or you're copying someone else, like, and certainly using stuff from overseas, because what's allowed over there isn't necessarily allowed.
You have to do your own due diligence. That's fair. I think this hour has absolutely flown by.
Fantastic.
I don't know if we have time for any speed fire questions, or
I think we've got 5 minutes.
Yeah, about 5 minutes. Okay, speed fire round, Annalene, and then we'll wrap the. I was going to say podcast. That's just ingrained within me. Our webinar up. But here we've got some questions. If there's a medical emergency, am I liable for it?
It depends. Did you cause it?
If I did.
Okay, so if there's a medical emergency in your practice, the first thing that we need to do is get that patient helped. Okay, medical emergency, patient has a heart attack, or even let's get that patient fixed. Let's get the appropriate people, commonly the paramedics. Let's not worry about whether or not we're liable. Let's get that person fixed.
Yeah.
If something happens in your practice and you've caused it, then yeah, you are. But that's what you have people like me for.
Yes.
So worst thing that ever happened in my practice,
yes.
hypochlorite reaction. Patient had invasive cervical resorption. I didn't realize it wasn't visible. This isn't a quick fire thing. This is like a long glass of wine, big cry story. It's the worst thing I have ever done to another human. And I had nightmares about it for years. This poor guy, in all seriousness.
Oh, goodness.
To be fair, the endodontist said there's no way I could have known about the invasive cervical resorption. Didn't make me feel any better. This patient suffered harm at my hand. It was up to me to get him fixed. And we did. But it was horrific. Like I say, that's a glass of wine and a tissue story.
We'll talk about it afterwards.
Totally.
If another dentist comes in to bail me out of an extraction or a root canal that I am stuck in, who's responsible for that patient?
Depends. So generally, you broke it, you bought it. So if a patient is having an extraction of a 3/8, say, and you're struggling, and then I come in and I take over, and that patient has a nerve injury, we will never know which one of us caused it.
Yes.
I'll blame you, you'll blame me. No, we will never know. So we're both in that because both our hands have been in that patient's mouth. Sometimes that makes mature age dentists feel that they don't want to come and help recent graduates, but I would say let's be fair and let's be reasonable. You don't just leave someone to struggle, and that's not a reason
the flip side, you were there one time as well. If the opposite were true,
absolutely,
how would you feel?
It's not a reason not to help. So both people would be considered to be involved, responsibility and everything. In all seriousness, if it's a legal claim, it's all worked out later by experts who work out the likelihood of who caused what injury. But yeah, you are in it if you help. But your insurance policy, certainly if you're with us, covers you for that. Covers you for supervising, mentoring, assisting, teaching. Because it's all part of life, right?
Yeah, that's fair. Last question here. What do you do if a patient refuses x-rays?
Don't take x-rays. Oh no, in all seriousness. Okay, so informed refusal is the flip side of informed consent. Okay, so informed consent, the patient needs to understand the nature and the purpose of the treatment that you're recommending. What you think is going to happen. They need to understand any alternatives, including the alternative of no treatment, if that's a reasonable alternative. They need to understand what can go wrong. They need to understand the consequences of what can go wrong and any additional costs that may be associated if something does go wrong. Okay. Informed refusal is exactly the same. They need to understand the nature and the purpose of the treatment. Why am I proposing x-rays? They need to understand the risk of not proceeding. I could miss something. And then they need to understand the consequence of that. And if I miss something, you could have toothache. You could have something which could be a small fix now and a big fix next time. Could be anything under those crowns. And if the patient understands that meaningfully, then they have the right to refuse your treatment. They don't have to follow your recommendations, and you document in the records. But I wouldn't just say patient said no x-rays. Because that doesn't demonstrate that you truly had informed refusal. I would be documenting what you discussed in those records.
Because I have two others. Sorry, I know that I said that was last, but I think there's two other questions. I think you would say the same response applies to those two as well. One was if a patient needs proper perio debridement, but they say I only want to clean, or
that one I'd go different on.
Oh, really?
Because if a patient's got perio and they need to see the specialist and they're refusing to see the specialist because they can't afford to see the specialist, if you sit there and go, well, I'm not scaling your teeth, who are you hurting? And who are you helping? Reasonably, it would be reasonable to do your best, making sure that the patient understood that you were doing your best, because the consequences of doing nothing, you know that disease is going to progress, right? So the patient needs to understand this isn't the solution, but it's a bit mean to withhold treatment from that person. Now, you can withhold treatment from people. You don't have to treat people if they're horrible to you, if they make you feel unsafe. But if someone just can't afford to see the perio, because it's expensive, I wouldn't withhold treatment from that person. But I would make it very clear that they are not getting specialist level care, that they need specialist level care. And if they don't go and see the specialist, they're going to lose their teeth. So see, same but different.
Sure, I see that. What do you say if the patient, like you're not comfortable treating the patient? Like you've had this discussion and like the interaction's gone sour and you just, how do you have a conversation about not, what, can you refuse to treat a patient?
Absolutely.
Yeah.
So the only time that you really can't is if a patient's an emergency. And even then, there are times you can refuse to treat people if you feel threatened or unsafe and you've had a breakdown of the relationship. I would probably say something along the lines of, Erica, what would I say? I'd say, Erica, I wouldn't say your name twice. I'd say, I sense that you don't trust me, or I sense you're not comfortable with me. And I think it's really important that you work with a clinician that you trust. On that basis, I don't think it's in either of our best interests for me to continue to treat you. I think the best thing is for you to get a fresh start with a practitioner who's going to be a better fit for you. I can either refer you or you can find your own practitioner, and I'll transfer a copy of your records to support you in your continuity of care. Now, what's fascinating is when you try and break up with a patient, what do you think they say?
But I want you.
But I only want to see you. And then you have to decide if the relationship is so damaged that you can't see them, or if you put some sensible boundaries around their behaviour. Erica, I understand that, and I'd love to continue to see you too. But you can't keep, in order to do that, you can't keep turning up 30 minutes late and swearing at me. That's not going to work for us.
Yeah. No, that's really fair and that's reassuring. I think.
And stop swearing at me.
Only if you stop saying my name so many times.
Bring me out.
I think that's wonderful, and I think what today has really shown us is like everything is you take a step back, look at it step by step. You know that there's always people that will have your back. Seek the support that's necessary.
Absolutely.
Don't do what you're not comfortable with, and that patients are understanding. You just have to treat them as humans as well.
Absolutely. And control that narrative.
Control
and
that
be
narrative
brave.
with sachet. Yeah,
be brave. And it's okay not to know everything. And it's okay to make mistakes. We all make mistakes. Even machines make mistakes.
Yeah.
Brilliant.
This hour has flown by.
I've
loved
hasn't it?
every second of it there.
You have. Thank you so much for taking the
you.
time to do this. And I think it was really important that your group of practitioners had one of them to pose these questions to, and to pose the questions to me. And I really hope we've covered off on all the things that people wanted to know.
Many,
Now, we do have the CPD QR code for those of you who've joined. So if you scan this code, it will take you through to provide feedback and also to collect your CPD certificate. Thank you so much for your time this evening. For those of you who are Dental Protection members, this webinar recording will be available on our e-learning platform from early next week. And thank you very much for your time this evening.
Have a good night.
Have a great night.
Oh, awesome.